Alcohols, as we know them to be, are organic compounds in which a hydroxyl group is bound to a carbon. But that's not how we'll approach to study it in pharmacology. In pharmacology, we're mostly concerned with the overdose toxicity of alcohols, chronic alcoholism, and drugs and measures used to overcome it. In order to better understand alcohol toxicity, first let's have a look at the different actions of alcohol on the different body systems. Firstly, on the CNS, it causes dose-dependent CNS depression. It causes stimulation initially and then later depression. The stimulation is because we don't know if it is inhibiting an inhibitory neuron that can lead to excitation. It has a facilitatory action on GABA A receptors, leading to depression. It inhibits glutamate action on NMDA receptors, which are basically excitatory receptors, thus leading to depression. In GIT, it causes irritation, gastric acid secretion is increased, gastritis, and peptic ulcer aggravation. Locally, it destroys lipid and proteins of bacterial membranes. That's why it is used as an antiseptic and as an astringent. It can cause fall in the body temperature, causing sweating, and alcohol sponges, etc., are used in fever to lower the body temperature. On CVS, acetaldehyde is a product of alcohol metabolism, which is a potent vasodilator. It causes cutaneous vasodilation, leading to flushing. It can also cause myocardial depression and vasomotor center depression. Alcohol causes serious respiratory depression as well. In the liver, when alcohol is metabolized into acetaldehyde by the enzyme alcohol dehydrogenase, the acetaldehyde, increasing level of acetaldehyde, causes consumption of the antioxidants and also leads to production of reactive oxygen species. This leads to hepatocyte inflammation and apoptosis, leading to cirrhosis and fibrosis. That's why alcoholics have a cirrhotic liver. On the kidney, it inhibits antidiuretic release, leading to diuresis. Now let's see how different types of alcohols are metabolized after they're ingested. They can be methanol, ethylene glycol, and ethanol. First enzyme they see is alcohol dehydrogenase. It will convert methanol into formaldehyde, ethylene glycol into glycoaldehyde, and ethanol into acetaldehyde. The next enzyme that will act on these aldehydes will be aldehyde dehydrogenase, specifically acetaldehyde dehydrogenase for acetaldehyde. It will convert formaldehyde into formic acid, glycoaldehyde into glycolic acid, and then ultimately into oxalic acid, and acetaldehyde into acetic acid. Now we'll see how these acids or their products cause toxicity in the body. One thing you need to remember is that alcohol dehydrogenase is a NAD+ dependent enzyme, hence it follows zero order kinetics, that is, a fixed amount of alcohol is metabolized in a fixed amount of time. Now we'll look at the presentation of toxicity of all of these metabolic products of alcohols. Firstly, formic acid will cause severe respiratory depression and thus respiratory failure. It causes metabolic acidosis, it's an acid. It causes ocular damage due to neurotoxicity. And a typical sign of methanol poisoning is standing out in snowstorm or flickering white spots before the eyes are seen by the patient. And formaldehyde breath can also be perceived. Now, when ethylene glycol or antifreeze causes toxicity, it will be converted ultimately into oxalic acid, which will cause respiratory failure and metabolic acidosis, as all alcohols do. And a special feature of this type of poisoning will be the formation of oxalic crystals, and they will cause acute tubular necrosis. This is reversible. Now, ethanol toxicity can present as acute toxicity due to acute intake of large amounts of ethanol and as well as chronic alcoholism. The acute toxicity will present as CNS depression, metabolic acidosis, acute hepatitis, and acute pancreatitis. Now, the increased amounts of acetaldehyde formed by the action of alcohol dehydrogenase on ethanol will cause some symptoms which will cause severe irritation to the patient, such as nausea, vomiting, headache, hypotension, etc. And this feature is basically used in alcohol aversion to make people not drink ethanol. We'll discuss more about it when we are discussing the management of chronic alcoholics. Acute toxicity also involves decreased availability of folic acid and thiamine because acetaldehyde will bind to folic acid and inactivate it, and thiamine is deficient because of inabsorption and decreased intake. Chronic alcoholism is manifested as fasting hypoglycemia, fatty liver, muscle wasting because there is proteolysis, and the alcoholics basically don't eat very well. They depend upon alcohol for their energy intakes. There is increased glucagon and decreased gluconeogenesis. There is also gout because we know that lactate, in order to be converted into pyruvate, needs NAD+, but in alcoholics the NAD+ is, all of it is basically used up by the alcohol dehydrogenase to get rid of the alcohol. So there is increased lactic acid which will compete with uric acid for excretion by the kidneys, and thus increased uric acid will cause gout. Another important feature of chronic alcoholism is Wernicke-Korsakoff syndrome. We know that chronic alcoholics have decreased thiamine in their bodies, so when a hypoglycemic alcoholic is given IV glucose, what happens is that the glucose cannot be metabolized because the enzymes need thiamine for their activity. So there will be hyperosmolar coma, which can be because of the glucose administered. So whenever you need to administer glucose to a chronic alcoholic, you need to administer thiamine with it as well. One thing to remember about chronic alcoholism is that the high levels of plasma ethanol in a chronic alcoholic's body cannot be handled alone by alcohol dehydrogenase. What happens is that the microsomal ethanol oxidizing system of the liver comes into play, and thus it converts the ethanol into acetaldehyde. We know that chronic alcohol is an enzyme inducer, so it will increase P450 enzyme activity, and as well as the enzyme synthesis will also be increased. So due to these two activities, what will happen is that tolerance to alcohol will be developed, and the same amount of alcohol which will cause toxicity in a normal patient will not cause toxicity in a chronic alcoholic. There will also be some drug interactions such as increased conversion of acetaminophen to its hepatotoxic metabolite, because that is also done by the liver conjugation. So we need to adjust the dose of these drugs, because increased conversion of hepatotoxic metabolite will cause fulminant hepatitis. Coming to the treatment of alcohol-associated problems such as withdrawal symptoms, alcohol dependence, and acute intoxication with methanol or ethylene glycol. To treat the withdrawal symptoms, we need to give thiamine because we know that chronic alcoholics are deficient in thiamine. We also need to administer benzodiazepines such as diazepam and chlordiazepoxide. We give these two drugs when we know that the liver function is normal, because these need a lot of metabolism and have active metabolites. While if we know that the liver function is compromised, then we need to give lorazepam, which is a short-acting benzodiazepine and has less complex metabolism, so it is safe in compensated liver function. Next, to treat alcohol dependence, we primarily use 3 drugs. First is disulfiram, second is naltrexone, and thirdly acamprosate. Now the disulfiram, as I previously mentioned, will inhibit aldehyde dehydrogenase. Now what will happen that aldehyde dehydrogenase, when is inhibited, will cause accumulation of acetaldehyde, and all those bad symptoms that I mentioned before, such as headache, nausea, vomiting, hypertension, will be associated with disulfiram use. So naturally the alcoholic will not want to drink alcohol while he's taking this drug, so it will cause aversion from alcohol. Other drugs which act like disulfiram are metronidazole, griseofulvin, and cefoperazone. They should not be administered in alcoholics. Secondly, we can use naltrexone, which will decrease the effects of endogenous opioids in the brain. And acamprosate is a NMDA glutamate receptor antagonist and a GABA A receptor activator, just like alcohol. Now, in the management of acute intoxication of methanol or ethylene glycol, what we do is that we can give ethanol or famotidine. Ethanol is given because it has more affinity for alcohol dehydrogenase than others, and acetaldehyde will not be as toxic as the other two metabolites, which were formic acid and oxalic acid, while this practice is now very obsolete. Famotidine can be given because it is a long-acting inhibitor of alcohol dehydrogenase, and thus the alcohol will not be converted into its toxic metabolites. That's all about alcohols.